Well, good morning, everybody. Welcome to Medical Grand Rounds. Next week, the Palliative Care Department will be hosting Dr. Ira Byock, who will be giving the talk, Caring Well for Patients Through the End of Life. Today, I'm really delighted to introduce a visiting speaker as part of our High Value Care series. And as a reminder, this series is devoted to hosting speakers who emphasize evidence-based and pragmatic clinical medicine that allows us to put particular emphasis on those practices that reduce waste and most benefit our patients. Today, I'm absolutely delighted to introduce Dr. David Bates. He is Chief of the Division of General Internal Medicine for Brigham and Women's Hospital and Medical Director of Clinical and Quality Analysis for Partners Healthcare. Dr. Bates is an internationally renowned expert in patient safety, using information technology to improve care. He's professor of medicine at Harvard Medical School and co-directs the program in clinical effectiveness at the Harvard School of Public Health. Dr. Bates served as an external program lead for research in the World Health Organization's Global Alliance for Patient Safety. He's the immediate past president of the International Society of Quality in Healthcare, was chairman of the board of the American Medical Informatics Association, and is editor of the Journal of Patient Safety. Dr. Bates has published over 700 peer-reviewed articles and is one of the most heavily cited biomedical researchers of any type. It is with great pride that I introduce today Dr. David Bates.
Thanks so much, and it's great to be able to be with you here. I trained up on the Hill, and it's always fun to be back in Portland. I consult with many different companies, but I'm not going to talk about any of them except for Early Sense, and I will present only data from Early Sense that's published and in the peer-reviewed literature. I'm going to start by saying a few words about accountable care. Then I'll talk about where we are with respect to health IT. I'll give you a general framework for some use cases for improving value. Then I'm going to tell you what we're actually doing. There's the theory of what we should do and then what we're actually doing, and they're not exactly the same. And then I'm going to give you a few overarching messages. I'll talk about innovation centers, which is one approach that many organizations are using, and we have one. I'll tell you about that, and then I'll wrap up. Where we're starting from is that we have a healthcare system that doesn't work. The costs of healthcare in this country today are unsustainable. We're spending 18% of our gross domestic product on healthcare, and the rate of costs keeps going up at roughly twice the rate of inflation. So that pretty clearly is not sustainable. And yet at the same time, we have relatively poor safety and quality compared to other developed nations, and we have this phenomenon of supply driving demand, which Atul Gawande exposed from places like McAllen, Texas. So to deal with this, the concept of the ACO has been introduced, and the notion of an ACO is that an organization will be accountable for cost and quality across the full continuum of care for a population. The idea is that we'll produce savings against risk-adjusted projected spending targets and bend the cost curve. People think that most of the savings will come from care coordination and avoiding complications in the chronically ill. There are strict performance criteria that have been put in place to try and prevent rationing, which happened the last time we went down this path. There are penalties for excessive readmissions that started in 2013. We've had to pay some big penalties. At the end of the day, the notion is that higher degrees of integration situated on top of a strong primary care base will increase savings and reduce penalties and improve patient experience of care. So, how do things look? I mean, today, we've been incented by volume. The notion is with integrated care, we'll be incented by value. Today, we focused a lot on acute illness, high-margin services, and the future, the notion is we'll focus on prevention and care coordination. Typically, in the past, our focus has been on the individual patient. We have to start to think about populations. We're still talking a lot about filling our beds. In the future, that won't be the aim. We'll want to try and prevent unnecessary admissions and readmissions. A key thing is that currently the payer has held a lot of the risk, and what will happen is that is going to be shifted to us, and that undoubtedly will create create some big problems. Throughout this, I'm going to argue that health IT will be a key tool. So broadly, the environment's changing. We have this pressure to reduce costs. There's more and more competition. And there are different payment approaches. ACOs are one. Bundling is another, where you get paid a set amount of money for delivering a bundle of care for a group of patients with a specific condition. Here's a map of the distribution of ACOs. This is from a couple of years ago. And you'll note that we have a lot in the Massachusetts area. There are not so many in the Northwest. I don't know if that's changed a lot. But on the IT front, we've been through a very big thing in this country with the HITECH Act and substantial incentives being put on place to try and get people to adopt health IT. And that has largely worked. Here are data about hospitals attesting to meaningful use. One of the things that people were afraid about was that the little hospitals or the critical hospital access hospitals would be left out. You can see that essentially everybody has adopted, and now the adoption rates are over 90% in the hospital side. They're also over 90% in primary care. So we've largely kind of gotten over the hurdle of adoption. But as I'm going to argue to you, the records are not necessarily doing today what we want them to do to help us get to where we want to go. Next, I'm going to talk a little bit about big data and using big data to improve clinical care. A lot of the things that I think we want to do to improve value do hinge on having access to at least reasonably large sets of data. This is a paper we published in Health Affairs, I think it was last year now. And we went through 6 use cases in this discussion. We talked about high-cost patients, readmission, triage, decompensation, adverse events, and then treatment optimization. And I'll take you through those quickly now. So high-cost patients are one thing that you want to focus on in terms of improving value. The reason is that about 5% of patients account for roughly half of spending, and your first step in managing this population, of course, is identifying this group. If you're going to do this, you have to include data about mental health, socioeconomic status, marital, living status, some things that we don't necessarily traditionally gather. And you probably also want to identify specific actionable needs and gaps. And if you can do that, it will make managing these patients much more cost effective. This is one place where we have invested, and I'm going to tell you here about this program that we've already put in place to do this. We take everyone who's in one of our ACOs and risk stratify them. And then for those who are high risk, we manage them pretty aggressively. And our population has actually grown since I made this slide, but this is because we just signed up for a big Medicaid ACO. But these are data from our Medicare ACO. In that ACO, we manage about 3,000 patients. 61% of them are female. Most of them are elderly, although there are a few young people. 32% have a mental health diagnosis, and that figure is actually probably an underestimate. A very large proportion of the people who are really expensive have some sort of mental health issue. They take an average of 17 drugs. The mean per member per month is $2,000, which is 2 to 4 times higher than average. And hospital admissions account for over half the costs. So we put in place some infrastructure. Every one of these patients is assigned a care coordinator. There's a patient registry. Providers get notified about admissions and ER visits. There's in the electronic record, there's a tool, and this circle moves whenever I make this slide. But anyway, there's an icon so that it's obvious to the provider that the patient is in ICMP, and it makes it easy to get in touch with their care coordinator. And we've showed that this has resulted in pretty substantial reductions in inpatient discharge rates, and also in some other parameters like ED rates and so on. I won't show you the data about those. But this has been pretty effective. We had an 18% reduction in the inpatient discharge rate. Readmissions are also important. Here CMS has strongly incentivized reducing their frequency, but readmissions are tricky, right? Because many of them are necessary. They're not unnecessary. But it is worth working on trying to reduce them. About 20 to 25% typically end up being preventable. You should use an algorithm to try and predict their frequency. I think some of the key differentiators here will be tailoring interventions to individual patients, ensuring that patients actually get the intended intervention, and then monitoring specific patients after discharge. We have 4 things that we try to do with every patient. We try to make sure that they get to see somebody within a week. We try to make sure that somebody calls them about their drugs, and a couple of other things. But it's really hard actually making that happen. Just doing getting them to see somebody within a week, has proved to be very challenging. We did get to the point where we were making appointments for everyone, but often the patients knew that they weren't going to keep the appointment, so there was, that didn't really solve the problem. And it turns out not everybody probably needs to get in within that first week, but there's some people who need to very badly. You really ought to figure out who those people are and just make sure that they get what they need within a week. Triage is another important opportunity. Here, I think the key issues are estimating risk of complications at times like admission, evaluation, somebody who has chest pain, or transfer. And if you're going to do this, you need detailed guidelines that clarify how the algorithm will inform care. Kaiser has done a lot with this and has done a very good job. They have some very good tools for evaluating newborns for early onset sepsis, and they also use emergency department composite scores to predict who's going to decompensate, and that has worked very well. Decompensation is also an important opportunity, and here I think the key issue is monitoring patients, especially outside the ICU. There are a lot of parameters that can be tracked with wearables or other devices. In the future, I think we'll also be able to think about many parameters simultaneously, especially in the ICU. Actually, today in our ICUs, we don't retain all the waveform data and kind of take it and set it up so that we can put it all together and predict who's going to do poorly. We're working on doing that. So here's an example of how this can work. This is a company that I've worked with named EarlySense, which is from Israel. They made this device down here in the bottom left, which sits between the mattress and the bed, so it doesn't ever touch the patient. And it measures the patient's pulse rate, their respiratory rate, and it tells you how much they're moving. The respiratory rate turns out to be especially valuable. In part, we don't really measure respiratory rates in the hospital. You'll notice if you look at the respiratory rate, it's 12, 12, 12, 12. That's not what it actually is. And if somebody starts breathing very rapidly or very slowly, it's an important clinical sign. So the way that this works is there's some smarts in the background. The data go from the sensor to the central processor. A lot of the noise is filtered out. If something important is identified, the nurse gets a message on their handheld that says, "Go take a look at Mr. Jones. The heart rate is high," and they can basically evaluate things. We studied this in a small hospital in the Los Angeles area and showed that in using this device, that the length of stay fell 9%. But more notably, the length of time that people spent in the ICU after this fell 45%. So you're finding people earlier and they don't get as sick, and the number of code blue events fell 86%. Another key thing about this is they filter out a lot of the noise, as I mentioned before. They had 2 alerts for every 100 recording hours, and fully half resulted in nursing action. In contrast, some of the monitoring technologies that we use all the time, like pulse ox, telemetry, cardiovascular monitors, have between 160 and 730 alerts per 700 hours. That's something that just needs to be dealt with and cleaned up. We did an economic analysis of this, modeled only ICU length of stay and pressure ulcers, and we showed that the break-even was within a half a year. And even using a conservative analysis, it broke even within 3/4 of a year. This appeared extremely cost effective. There are other technologies like this. This is not the only one, but I'm convinced that we will want to start monitoring people even outside the ICUs using some approach or another. Okay, so now we're gonna switch over to the Brigham and talk a little bit about accountable care. We have about 1/3 of our population in some sort of ACO-like arrangement. We have a Pioneer ACO, we have a variety of commercial payers that we have ACO-like arrangements with. We have an arrangement with Blue Cross, which is called the Alternative Quality Contract. This was very controversial for us. Initially we tried to stay out of it. The way things work is it's really easy to get your bonus in the first couple of years, but then they make it progressively harder in the succeeding years until it's like completely impossible. And we don't have any bundling yet. We keep having conversations about that. We've been afraid to get engaged in bundles, in part because the last time we did this, we lost a lot of money, and we haven't known exactly how much things really cost. And it's pretty risky to promise to do something for a set price when you don't know what your costs are exactly. All right, so here's an overview of some of the things that we're actually doing. The very first one is this managing of high-cost patients, which I told you about. That's called the Integrated Care Management Program. A second is SCAMPS, which I will describe in a minute. A third is we put in place an enterprise data warehouse. We have a variety of different analytics tools that we're putting in place. We are trying to think about changing the way we do cost accounting so we have a better sense of what things do actually cost. We have an ICU and a general care unit checklist and dashboard, which I'll tell you about. We're doing some electronic care coordination, which I will not talk about further, and we've really improved our registry capabilities. So next, let me tell you about SCAMPS. SCAMPS are Standardized Clinical Assessment and Management Plans. And the idea is that these are a tool to align standardization with culture of innovation and academic excellence. They have several key features. The pathways are developed by our physicians. Deviations are permitted and encouraged and tracked, so it's different than guidelines. You're actually encouraged to deviate, but when you do deviate, you have to say why you did it. And the notion is that there will be continuous improvement to the pathway through robust data collection. So you collect data on what's going on and see what decisions people made and what happened. Here are the 12 SCAMPs that we've done since May 2012. Includes things like distal radius fracture, breast reconstruction, inpatient chest pain, and so on. Some of them we did not learn that much from. So for example, with breast reconstruction, we thought there was going to be a lot of variation, but there wasn't. And that one ended up not being that interesting. On the other hand, things like acute kidney injury in the MICU resulted in actually very substantial improvement, both in terms of outcomes and in quality. And the ones I'm going to focus on today are distal radius fracture and chest pain in the emergency room. Distal radius fracture is an interesting condition. It turns out that there are just 5 physicians in our place that manage most of those patients. They'd never really, though, gotten together and talked with each other about how they actually manage distal radius fracture. It's not like bypass surgery where they've been really beaten over the head for a long time. And it turns out when we just measured what their operative rates were, there was big variation from person to person in terms of what the operative rates were. So the things that they thought were important in terms of decision support and the decision points were who to take to the OR, whether you put in hardware, and then how much physical therapy to do. I wouldn't have known going in kind of what the points that people would vary were, but they were able to come up with these. And what we found at the beginning is what you often find. There was big variance by provider in terms of what proportion of people they took to the operating room. But after they came up with some criteria and then started trying to use those criteria, you can see that they all moved towards the mean, and there was an 11% reduction in surgery overall. And there was also improvement in costs of 14%. And we see this kind of improvement for almost every condition that we study. Here's an example for chest pain. Here we are looking at chest pain in the emergency room, and before the SCAMP, compared to after the SCAMP, there was a 54% reduction in the percentage of patients who got a stress test in the ED. There was a 27% reduction in the percent of people who were admitted to cardiology or medicine, and an 11% reduction in per patient costs. We projected that extrapolated to about $4 million in cost savings if you assumed that everybody was in some sort of ACO-like arrangement. All right, next I want to just tell you briefly about our enterprise data warehouse. One thing that every organization needs to do is to figure out where it's going to put its data and then set it up so that people can get at it. This is a partners-wide data warehouse, and we take data from our clinical systems and put it into the data warehouse. But there's other data that goes in there too. There's claims data, other types of data which are not clinical data. We decided to focus on time to value, and we tried to pick things that address pressing business priorities. We tried to avoid multi-year efforts to build a monolithic, multi-purpose data structure. There were three things that our governance team identified as important priorities. These were healthcare directions, which are drivers that affect hospital volume and margins. Episodes of care, which looks at variation in the longitudinal experience of patients across inpatient and outpatient. And then finally, population insights, which is focused on measuring and monitoring medical expenses and utilization that drive trends in populations. We had to make the decision, should we do this all ourselves or should we work with a partner? And we elected to work with a partner called Health Catalyst. We picked them for a couple of reasons. They were an industry leader. They had a strong methodology. They're from Salt Lake City. They'd worked with a few other large systems. And in addition to being an implementation partner with us, our innovation fund invested in them, and we're trying to co-develop analytic content. That's a model that we would like to try and pursue more broadly, although we haven't done it. This is really the first time we've done it in a very big way. Then you have to set things up so that people can actually get at the data. And we have a variety of different front-end tools. There's a non-managed access gateway that you can go to with your own tools if you're pretty sophisticated. But there's also a managed access gateway for people who are a little less sophisticated, and that uses an application called QlikView. And then there's another one that runs through Business Objects that lets you just get at the data from Epic. And everybody will need a variety of approaches to let you actually get at the information that is in the database. I have to say, our database now does have all the things that we wanted in it, but you have to be pretty sophisticated to find what you want. If you're just a doc and we're sitting down, you could basically not work with this very effectively. We'd like to get to the point where you could, if you say we're the person in a group that was responsible for managing care, work with things. Another thing that we've done is to try and develop a new view on costing. And here we worked with a company called ValueScope. They have an approach called clinically driven patient costing. What this does is take data from the electronic record and other clinical systems to better identify the cost of clinical activities. Many of the traditional costing approaches don't assign any costs to things like social work or often even nursing time. They make the assumption that everybody gets exactly the same amount of nursing time, and that's just not true. ValueScope also lets us expand beyond the inpatient setting to include both pre- and post-acute settings. It facilitates costing at the appropriate level of sophistication. All our costing before has focused on the inpatient side. This also leverages internal costing work already done for the inpatient setting, and it avoids lack of scalability and one-time study issues of time-driven, activity-based costing efforts. Michael Porter, who's from Harvard, has really pushed on the notion of time-driven activity-based costing. And if you're going to do that, what you do is you watch people who are getting care and figure out exactly how long it takes to do every specific activity. But it took us 2.5 years to do one condition. So it was clear to us that we were not going to get through what we needed to do at that rate. And this seemed to us like an approach to do something that approximated time-driven activity-based costing, but it wasn't going to take forever. The idea also is that this will integrate costing. It lets you do revenue modeling, lets you factor in quality, and finally, it helps you figure out how you're doing with your ACO, with bundled pricing, and with medical home opportunities. And it contains a lot of tools that let you model alternative scenarios. Oops, sorry. We've also put in some approaches to try and enable use of analytics at the Brigham. And for a long time, we've tried to use data in our decision making. We have a tool called the Balanced Scorecard, which when it came out was really state of the art, but that was 15 years ago. It includes data from both the Brigham and from our network, and there's some other data that is available in it. Mostly it includes two-dimensional reporting, and there are a lot of canned reports on what actually happened. There's a little bit of interactive analysis capability, but frankly, not very much. And when we asked leaders who were trying to measure value, do you like this? Do you use it? They mostly said, no. I have an analyst who looks at it sometimes, but I can't figure out how to use it myself. So we're trying to move to a better place. We want to, in our next iteration, be able to do a lot more predictive modeling using both internal and external environmental data to try and predict what will happen. We want to try and do a better job with predicting staffing models. We want to be able to predict margin rates based on market shifts and use complex statistical analyses to look at patterns and variations. So here are a few example projects that we have been working on. One focuses on the obstetric inpatient census and other patient volume. We've tried to predict obstetric census and other patient volume and leverage predictive data to determine staffing needs. This became especially acute because one of the big payers in our area basically took all their patients, which accounted for 40% of our obstetric volume, and they shifted them to another institution. So that kind of created a crisis for us because we had all these staff, but no patients for them, and it was hard to figure out exactly how we should staff. A lot of focus on targeted high-risk care coordination, so finding the right people and then managing them more effectively. We're going to work on decompensation along the lines of what I told you about early sense. Another area is managing chronic patients, trying to predict an individual's disease trajectory to allow the caregiver to better provide the appropriate treatment. Big focus on looking at variation. In general, anytime that you can find variation, that's a worthy target. We are trying to improve our ability to manage bundled payment, and we're going to totally revamp the Balanced Scorecard, take it and start over, and we're coming up with a new tool. Now, the study that's gotten me the most excited over the last couple of years is this study, and this was a research study. It's not operational work. It was a study called the PROSPECT study, which stands for Promoting Respect and Ongoing Safety Through Patient Engagement, Communication, and Technology. Was funded by the Gordon and Betty Moore Foundation. And our goal was to transform the intensive care and oncology environments through implementation of a patient-centered intervention. We focused on both patients and care partners. The intervention included two main chunks. One was the patient satisfactive model, and what this is a different way of trying to have physicians and nurses interact with patients. The backdrop here is that we've done some work that in which we asked doctors and nurses, do you ask patients what they expect? Do you think you should ask patients what they expect? They all said yes. Then if you ask them, do you actually ask them what they expect? They say, well, no, I'm too busy. I don't get around to that most of the time. And in a prior study, we did an intervention and showed that if you just ask people what they expect and then try to meet those expectations, that decreased the length of stay by about a half a day. So, proved to be a pretty valuable intervention in itself. The second thing we did was to build a web-based patient-centered toolkit. And here, what we did was ask patients and families what they wanted to know about the inpatient stay. And then delivered all that. And we expanded this to include a suite of provider-facing tools, which includes a microblog. So on the patient-facing side, the providers actually could have a conversation about the patient, and they could have a conversation about the patient that either included the patient or did not include the patient. And then on the patient-facing side, I'll show you the tool in a second, we gave them all iPads, and that included lots of information about their care. And we did need patient or healthcare proxy consent, so a lot less people use the patient-facing tools than use the provider-facing tools. Everybody got the patient satisfactive model. Here's what the iPad interface looked like. People said that they wanted to know who their care team was. They wanted to be able to send messages. They wanted information about safety, and we showed them actually how we were doing on the safety checklist. We showed them all their test results, their drugs. There's information about food and diet, discharge information, and we worked a lot on goals. We didn't get as far with this as I would have liked in this study. I think there's a lot more room to do that, but I think establishing goals and then seeing whether or not we're meeting them is going to be an important thing going forward. On the safety front, we built this unit-level dashboard, which providers really like. Now, this is the ICU dashboard. We built this outside of Epic, but it looks to providers like it's in Epic, so they appreciate that. And you can basically see that what you need to do is focus on the red and yellow cells. And the way things work is if there is a red or yellow cell, you can just mouse over it and see what the actual issue is. So here's what the patient-level dashboard looks like. We've taken data from the record and then show it to the providers. And again, you can see what's yellow and what's red. Here, Hermione has an issue with their urinary catheter. It's been in for 10 days and should be replaced. We studied this in a controlled trial, which just came out in Critical Care. It's available online, but not in the paper version. And we showed that the harm rate fell by about a third. The patient's ratings of us increased dramatically. The satisfaction of care partners increased dramatically. And global concordance also improved. Resource utilization did not change, somewhat to our disappointment. But people really like this. Broadly, I think we're going to want to do a lot with integrating predictive analytics into high-value care. And what we suggested in this piece in JAMA was that we should be using data, in routine ways to help make better decisions across a variety of dimensions. There are a number of ways that our electronic records today fall short. Decision support falls short both in terms of the content and then the mechanisms for delivering it. We have Epic. Epic in particular does not let you deliver decision support in some of the ways that turns out as most effective for getting people to actually do things. We don't do so well with extracting information from the record in real time. It's easy to get it on a daily basis, but getting things in real time is not trivial. Our tools today are not as good as they should be for enabling population health management, which, as we've discussed earlier, is where we pretty clearly need to go. There is limited information in real time, but it's hard bringing those insights back because, in particular, both Epic and Cerner don't let you bring messages back into the provider very readily, and the electronic records today don't make it that easy to measure quality, safety, or efficiency. Real-time data, if we could get at it, could help in a variety of ways. It could help detect compensation. It could help find patients at risk for adverse events, things like sepsis, renal failure, or other types of adverse events. It could help ensure that patients get context-specific best care across many conditions. We need to be able to change management across many domains in real time, like pick the best procedure for a patient or interpret complex results. So, what's going on at the Brigham? Well, locally, we expect that we're going to have a flip from where we are today to mostly value-based care in the next 2 to 3 years. But, we're still in this position where there's a lot coming in from fee-for-service, so it's hard to just make a big bet on this. We have way too many specialists to support, and we have all these things that have been very big profit centers but won't be under the new system, like high-cost radiology, so that's complicated. Our ACO is run by our specialists. National data suggests actually that all the ACOs that are doing well financially are run by primary care providers. We don't have the infrastructure that we need, really, to manage under value-based care. We're still actually kind of reeling from our Epic implementation we just implemented about 3 years ago. And we're working on developing all the governance that you need to make all the changes that everybody wants. We have this enormous list of changes that we know we want to do, but if you look at how fast they're coming in, it's not very rapid. There are a number of addressable benefits. I think we will be able to bring data together to get new insights in real time. If we put in place devices with interfaces with all the various devices so that we can bring together information that's already being gathered, that'll be helpful. There's a lot of improvement that's possible on the decision support front. Tools to help us assess costs, like what I told you about this approach to activity-based costing, I think will be reasonably useful. And we've got to have a strong analytics plan and a strong toolkit for enabling people to use data. One approach to enabling innovation, this is setting up innovation centers, and we've set up one, and a number of other entities have. I just wrote a paper for Health Affairs in which I described the approaches that various organizations have used around the country to this. At the Brigham, we have an innovation center called the iHub. The focus is really on using health IT to innovate, and we focus there actually mostly on things that will be commercial successes, and the clinical innovation is run through a separate group, which is not necessarily, in my opinion, the best way to organize things. I think it's better if those things are together, but that's not the way that we have happened to do it. At Mayo, for example, they have a huge innovation group. Our group includes 3 people, to give you a sense. At Mayo, they have something like 75 people working in their innovation group. That includes both clinical innovation and investment. University of Pittsburgh has made a big investment in this area. They invest in small companies and co-develop, and I'll give you an example of that in a minute. University of Pennsylvania has a big innovation center. Their focus is mostly on care redesign, taking different aspects of care and then really rethinking it. UCSF has established a center to enable testing of mobile applications, so a very, very specific focus there. If you take the leading innovation centers and kind of rank them on their focus on external stuff like developing companies versus internal focus, making care better, this is the way that I would rank them. So Cleveland Clinic is perhaps most externally focused. Geisinger is somewhere in the middle. Pittsburgh is squarely in the middle. Pennsylvania is at the other extreme with a focus really on internal things. And here are a few specific examples about what some of these centers have done. Cleveland Clinic has a process called Invent. Their idea is basically to take a product all the way from concept to commercialization. They're very good at doing that. And they've produced a number of new devices, many of which are surgical, but also some health IT innovations. Pittsburgh has this approach of finding small companies that it thinks are doing something that they need clinically, and then they invest in them. DB Motion is one company that they invested in. What DB Motion is it basically takes your data from whatever clinical system you have, normalizes it, and sets it up so that you can see it anywhere else in your enterprise. And UPMC has this huge operation with, like, I don't know, 15 or 20 hospitals and lots of different clinical sites. And DB Motion basically made it so that the data flowed everywhere, within that enterprise. And that was eventually sold for $235 million. Geisinger has this set of tools called Proven Care. It takes its care improvement tools and then sells them to other organizations. They're essentially roadmaps for redesigning your clinical systems. Mayo has this Center for Innovation, which is focused on improving clinical value using a design-based approach, combining principles of human factors design, scientific method. One of their poster children is eConsults, which lets patients have video chats with specialists in real time. University of Pennsylvania uses designers to try and do a lot of the clinical redesign. And for example, for late-day discharges, they've produced several new solutions, including outpatient rehydration, some new scheduling policies. There's some pitfalls to doing this. One key one is failing to insulate the innovation groups from operational demands. They really, need to be separate. Another thing that I think we've been guilty of in a big way in healthcare is investing in innovation. Big firms invest 10 to 20% of their gross revenues in doing this. I mean, we are so far from that. Another way to have issues is to not set up methods to reinvest your innovation profits. If you do have money that comes in from doing this, you gotta set up ways for plowing it back in and not just applying it to the bottom line. And then finally, if you are going to try and do something like this, you have to take a long-term view. It takes, if you set up an innovation center, it takes about 5 years on average before you have any really substantial returns. And if you're not willing to wait that long, you shouldn't do it. So let's take a step back. Broadly, I'm concerned that our specialist heavy academic medical center workforce may jeopardize ACO readiness. If you look at the ideal ACO physician distribution, this is what it looks like. There are few subspecialists, more specialists, and more primary care and even more community care and supportive services. But this is what we sort of look like today. At least at the Brigham. So other questions: how much integration do you need to be competitive? How much cultural transformation do you have to have? What do we need to do with stakeholder alignment? For the academic centers, how will changes in reimbursement affect the tripartite mission? In particular, how are we going to fund education and research? Typically, we've been funding that from clinical care. That is going to be harder. Very importantly, if you do have some shared savings, how will they be distributed? Again, if you have all specialists running your ACO, they could just go back to specialist salaries. And then finally, how do we weather the transition zone between fee-for-service and ACOs, since the incentives are not really aligned today? So to wrap up, I think this is an exceptionally exciting time in healthcare. There's lots of innovation going on. The major driver in the U.S. is high costs. I will note that care outside of the hospital accounts for 70% of our costs. We've got to do a better job in terms of thinking about that, how to manage things. There are huge changes going on in the IT space. Things like analytics, sensing, and communications are all going to be powerful tools for improving care. It's not all about data. I talked a lot about data in this talk, but it has to be a pillar. You have to have your data. You've got to be able to access it. You've got to be able to ask questions of it. There are so many opportunities to make care better and to rethink how things are done. And I think successful organizations are going to prioritize this. And you have to not just innovate, but then after you innovate, you find something that works, you've got to find an approach for actually spreading it. We have fallen down in this particular area. Sometimes we show that something works, but then can't really muster the resources to get everybody to use it everywhere. And I would suggest that physicians mostly embrace this, particularly younger physicians like this. They find it exciting. I think the hard part is for the leadership to basically make a strong move and make the changes that are needed to get us to where we need to go. And I will close with a couple of quotes. Darrell Royal, who is a great University of Texas football coach, says, "Potential means you ain't done it yet." And Mark Twain said, "I support progress and innovation. It's change I don't like." So I'll stop there and take some questions. Yeah.
Super inspiring work. Back to the notion of stakeholder engagement and the pathways you described with the distal radius fracture as an example. I'm thinking about some efforts at our own organization that have been somewhat clumsy, perhaps, in their efforts to say, make a pathway for C. difficile or make a pathway for sepsis. And then some pathways that I think would be great, like forcing the physician who is about to order insulin to reduce the basal dose by 20% since our hypoglycemia rates are in the 4% range. And I'm wondering how you work with your stakeholders and how you get them to give you the feedback you need to revise the pathway. You kind of force them to say why they deviated.
Yeah. Well, people don't, great question. People don't like to be forced in one direction. And one of the reasons that SCAMPS has worked so well is we don't tell you what to do. There's sometimes when you should be told what to do. If we really know you're going to order a dose of a drug that's too high and that's going to routinely get you into trouble, you should just put in a forcing function and get people to live with it. But for most things, in medicine, we really don't know exactly what to do. And that's why approaches like SCAMPS are so powerful. Physicians feel empowered by that. They like coming together and thinking about how are all the different ways that we're managing things and what is the best approach to getting to where we want to go. With SCAMPS, there is nobody telling you what to do. You really just collect data and then sit down periodically, go through it, and then refine things. So I guess at the end of the day, I think it's best to use approaches like that bring people together, that engage them, and that move them in certain directions without telling them this is what you have to do. Yeah.
One of the big things is raising costs of the cost of drugs. You didn't mention anything about that or anything you're going to do. If you're going to bundle something, how are you going to account for that?
Yeah, of course, we're doing lots of stuff with respect to that, and you're absolutely right, especially the biologics and some of the SCAMPS that I didn't talk about do focus on that. And it turns out that there's a big opportunity. So if you're managing MS or IBD, inflammatory bowel disease, building some consensus about what approach to use and what pathway to take can probably result in better outcomes and substantially reduced costs. That's going to be a big challenge, I think, though, for the foreseeable future, because it seems like, every year there's some new blockbuster thing that becomes available, and it's hard to figure out how best to use them. Come here.
Around the issue of cost, now what you're talking about, where it's successful has magnificent outcomes in terms of physician behavior, patient behavior, and making the most of the resources we have in a way that most benefits patient outcomes. The issue that is raised about this external force over which we have no control, the outrageous cost of biologics that have nothing to do with the real development cost of these products. It would seem that what you are doing and people of like mind are doing is also creating about which medicine to use as a mechanism for pressuring, gaining some leverage against these companies. Right now what happens is a pharmacy committee, in all good intention,
Yeah.
makes this blanket that's a nightmare. And the kind of work you do would seem to be able to inform that decision-making in a way that doesn't have adverse outcome in terms of healthcare.
Yeah, no, I think that's exactly right. And what we try to do actually is for each expensive drug to try and stay ahead of things and be prepared and have a guideline ready actually that we can turn on day one so that everybody gets used to using these new agents in ways that are appropriate. I mean, I also think that there are other things that should be done, for example, at the federal government level to help work with these companies to rationalize things a little bit, because other countries don't have to pay what we're being asked to pay today. But we also sort of have to play the hand that we're dealt. That's not something that at an organizational level we can change. But we absolutely need approaches to just be able to jump in when something new comes out and just manage it effectively right out of the box. Yeah. Oh, did you have a question? No.
I was just going to ask how your organization is balancing the extra clicks, as it were, to gain the data and the measurements that are needed to sort of accrue part of the value formulation that your organization is trying to advance.
Yeah, so we're trying to absolutely minimize that. I mean, we've done some empiric work to show that just switching from our old system to Epic, the number of clicks just to do anything has gone up, really radically, and that, for obvious reasons, makes people reluctant to do anything else. So we do our level best to try and only ask things when they're absolutely needed, when there's nobody but you who can supply the information. If there's any way to get it out of the record, say from someplace else, we try and do that. If your practice assistant could ask the question, we try and do it that way. So I think we want to set things up so that we're asking specifically the docs to do as little of that as we possibly can, and shift as much as we possibly can in other directions. We try pretty hard to avoid that, and I think that should be a top priority because there's enormous pressure on us today. Yeah.
I had a question about the SCAMPS. It seems like SCAMPS is highly effective in single entity organizations, but I'm kind of curious about scalability as you start getting into multiple enterprises or multiple facility enterprises. For instance, Providence, just in the Oregon region, is 8 hospitals. Otherwise, we're 34 hospitals, and we're trying to standardize from an EHR standpoint, so that scalability becomes a little bit more challenging. So have you seen it work in other institutions that are multi-facility?
Well, it has worked to some extent, but scaling it has actually been a pretty substantial issue. And we set up a not-for-profit company that was focused on trying to scale these, and decided, in fact, just recently to fold it because the way we'd set it up from the business perspective, we were not able to kind of make it work. But I think that so I think it is a challenge to scale them. I also think it will be possible to do it. Once you set things up in the right way, and in particular, once things are really well interfaced with the information system, so that it doesn't create a lot of extra work for somebody, and that you don't have to have someone asking a lot of additional questions. So you put your finger on an issue that is a problem with SCAMPS. Yeah.
We've been talking a lot about scams, but it's not clear in my mind what it is that a scam is. Can you give us an example of how you operationalize?
Sure. So what scamps are basically operational approaches for dealing with a question. You identify 3 or 4 decision points in managing a condition for a radial fracture. That is the ones that I mentioned. Do you take them to the OR? Do you put in hardware? Do you how much physical therapy do you do? And so you're just asked to record what you did at those 3 points when you're managing a patient with radial fracture. And and over time, you collect data about what happened to people you did take to the OR, didn't take to the OR, and what their long-term outcomes were, and then compare cost and quality for that population. So it's basically a structured approach for managing a specific condition in which you collect data around these key decision points. Does that make it clear? You bring together the people who are managing those patients, have them meet, they decide what they think the decision points are. We typically have a research assistant actually then go ahead and in the beginning collect the data. Over time, we ask the providers to actually tick the box. But for things like, did you put hardware in or not, that we can figure out pretty readily.
And the movement towards the mean, do you know that you ended up at the right place?
No, it's hard to say what the right place is, and you don't necessarily know what the right place is. Yeah.
I want to ask Jane, it looked like you didn't move the needle too much on knee replacement, so I'm wondering, are you already evolving towards outpatient arthroplasty and how you're doing in that?
Yeah. So
That's an example of
no.
what I'm asking about.
Yeah, no, that's a good example. Well, knee replacement, we did not have a lot of improvement there. Knee replacement is one that has been worked on a great deal. The next thing for us to do is to do outpatient arthroplasty, as you suggest, and our surgeons are just still really nervous about it, and they haven't been willing to kind of step over that threshold. For those of you who don't know, Mayo does that, for example. You guys may be doing it here. It's worked really well. But it's a scary thing for the surgeons who are actually doing the procedures, and there's some patients who are not candidates, clearly. Yeah. Yep. Yeah.
For those institutions that are participating in bundle payment,
Yeah.
what do you think is the difference that allows them to get there and take those risks as opposed to where we need to be? And how long do you think it will take using your information system and the data that you would have before you get there?
Yeah, I think the key thing really is just having a very good sense of what your actual costs are. And in particular, so like for the knee bundle and the hip bundle, you have to have a good sense of what your costs are for the post-discharge part of things, because those are actually most of the costs. And then you have to set up approaches for managing those costs. We've never worried about that at all in the past. So if you don't have a good sense of those things, and then, for example, good partnerships with whoever is going to care for the patients in the community, then you'll struggle. So those are really the keys for that.
If you can't get your specialist to get that mindset, isn't that going to be a major?
Well, it'll be a huge issue, but CMS has said that all payment for total knee and total hip is going to be through that, and they're going to be throwing a lot of other things into that area in the not too distant future, notably treatment of some of the common cancers. So the specialists will either have to get on board or get off the boat. Yeah. Okay.
We're at 9 o'clock. Feel free to come down.
Thank you.